Hello, we're glad you've joined us for this live webinar, CDC Evaluation of a Two-Tier Lyme Disease EIA Testing Method and Potential Diagnostic Significance. I am Judy O'Rourke of LabRoots, and I'll be moderating this session. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. It's brought to you by bioMérieux. A world leader in the field of in vitro diagnostics for more than 50 years, bioMérieux is present in more than 150 countries through 42 subsidiaries and a large network of distributors. bioMérieux provides the diagnostic solutions, reagents, instruments, and software which determine the source of disease and contamination to improve patient health and ensure consumer safety. Its products are mainly used for diagnosing infectious diseases. To learn more, visit www.bioMérieux-usa.com. Let's get started. You can pose questions to the speaker during the presentation while they're fresh in your mind. To do so, simply type them into the Q&A box, which will open when you click the green Q&A button at the lower left of the presentation window. Questions will be answered after the presentation. To enlarge the slide window, click on the screen icon in the lower right-hand corner of the slide window. If you experience technical problems seeing or hearing the presentation, just click on the support button found at the top right of the presentation window, or report your problem by clicking on the green Q&A button at lower left. I now present today's speaker, Lena Prisco, PhD. Dr. Ursula Lena Prisco has a PhD in pharmacology. As a laboratory and clinical researcher and as a former laboratory director at Martha's Vineyard Hospital, Dr. Prisco serves as a clinical researcher and consultant for many health-related and laboratory organizations, including bioMérieux Incorporated, Quidel, and Medscape. Dr. Prisco will now begin her presentation.
Good afternoon, good morning, and thank you for joining me. I'd like to spend today talking to you about two-tier Lyme testing and incorporating the current CDC manuscript that was written recently regarding this test. As Judy said, the second slide actually shows a little bit more about me. I was an early adopter of this VIDAS Lyme 2 dissociated assay, and I have run thousands of specimens using the assay. I will show you data that I presented in 2015 using this assay in a validation protocol, and I am currently on the Dukes County Health Commission. So if you'll forgive me, for those of you who are familiar, more familiar than others with Lyme disease, I thought I'd ground us for a few slides in Lyme and ticks in particular. So if you look here on the left of your screen, that is the black-footed tick, Ixodes scapularis. At the bottom in the middle is a tick that is engorged and unengorged. And you'll notice the dramatic size of when a tick has been feeding. This particular tick, for those of you who are wondering, was engorged and was feeding for, we estimated when we took the picture, about 36 hours. Up in the right-hand corner is a hematoxylin stain of a spirochete taken from the spinal fluid of an infected patient. So one of the things that actually makes this disease transmission difficult is that the size actually matters. Now, there are lots of different ticks, and you'll notice on the left, you'll see the size differential between an adult male, female, a nymph, and a larva. And then there's the Lone Star tick, and at the bottom, the dog tick. So most of us are familiar with the larger dog tick, and those of us who have dogs, cats, etc., we routinely pull these off our animals. However, in the case of Lyme, size really does matter. If you look at the picture on the right, you'll see how small that nymph stage really is of this tick. And this nymph stage is the most infected form of the transmission of the disease. And because of its small size, it's not always easily detected, even on clear, visible on clear skin. And it likes to congregate in certain areas where you may not detect it at all, and that is in hairlines, in socks, legs, pants, etc. So it makes it particularly difficult to know that it's there. So one of the other things that's important is to realize that the life cycle is a 2-year life cycle for these ticks. So it actually begins, if you start on the left in the spring, the larva, the female tick, drops off its deer host and lays the eggs on the ground, and the larva begins to develop. Most of the transmission actually starts through the white-footed mouse. The larva feeds on small animals where it's picked up, and the mouse then transmits it through the brush, etc. We end up in the fall and winter where the larva becomes dormant. In the following spring, the larva molts and then turns into the nymph, which is the most aggressive stage. The nymph then is usually, along with the mouse and feeding on the deer, is transferred to another host, and that host often, for people who are walking in the woods, etc., brushing up against leaves in their yards, etc., becomes a host, and that's when they become infected. The nymph then grows to adult, and we start all over again. It's interesting to know in years where the winters are mild, and particularly here where I'm located on Martha's Vineyard, the adult ticks are not killed, so there's a greater production of food for both the mouse and the deer, and then all that also produces a consequent rise in the tick population, because ticks are not killed off as well. So I put this in here because I wanted to show a progression of our ability and our knowledge of detecting this disease. So if you look at the color, I want you to focus on the darker colors, where those are the areas of high risk. And this was from the National Lyme Bank predicted database in the year 2000. So we're talking, 17 years ago, where you can see in those dark areas where that really was the areas that we, considered to be high-risk areas. But I want you to look at the pink areas as well, and notice that in the southeast and the west and the upper west, and even in portions of the Midwest, there was considered to be a very low risk of disease in 2000. If we then look at CDC reported cases in 2001, you start to see these dots where there begins to be a bit of a spread, where not only do we see the same dark areas in those same areas that we were aware of, but now we're starting to see cases in Florida, Texas, a higher concentration in Ohio, Minnesota, California, and up in Washington State. From there, we move to 2015, and now you can see the dramatic difference, where there is a much higher concentration in the Northeast. It appears to be spreading south. The concentration in the Midwest is much heavier, and there is now more and more incident reports in Florida, California, and in the Northwest. So here shows a graph from the CDC Lyme database as of 2015 and what they call confirmed versus probable cases. Now, probable cases are those that, based on serologic testing, were equivocals. So if we looked at confirmed cases only, those are the darker bars, and that really is based on serology. It's also important to note that these numbers do not include patients who present with symptoms and may be treated without serologic testing. So these are only patients who reported positive by serologic testing. Now, there's been a lot of talk about why there's a difference between reported and actual cases and why the discrepancy. And recently, I'm sure you've all heard that there are reports now that the CDC does actually estimate that the actual cases may be in the range from the mid-200,000s to close to 460,000 and more cases. And there are several reasons for that. The actual confirmed patients must have a bullseye rash. Now, for some areas, not everyone gets a bullseye. So we're talking about, at the most, a reported 70% of patients with a rash. I can say here on the island where we have a very high incidence of Lyme disease, there's probably only about 35% of the patients that we actually see in any given summer who come in with a rash. So it's either they're coming in before the rash develops or they never develop one. The other issue is to be positive. You have to be positive in serology tests. And many cases are diagnosed as having Lyme disease based on symptomology alone, and a lot of clinicians will not then test. They just diagnose the patient based on symptoms, with or without the presence of a rash, and treat them. The third issue is positive results are reported to public health offices where the patient's primary residence is located. So if you look to the right, some of these case numbers may be slightly off. As, for example, here on Martha's Vineyard, we have many people who come here to visit who were probably bitten here by a tick, become infected with Lyme, but actually go home somewhere else where they're diagnosed. So our actual incidence and prevalence numbers may be incorrect. So I can imagine that, may happen in other places throughout the world as well. And finally, most health agencies send paperwork to physicians to fill out this report on Lyme disease. And I know for us, one of the cases, and now that we have electronic medical records, et cetera, physicians are inundated with all kinds of administrative tasks that they have to do, and the paperwork isn't often filled out, mainly because they also, in the physicians I have spoken to, feel that it's not a communicable disease, so they're less apt to fill out that paperwork. So when we talk about the tick life cycle, we also can map that back to a distribution of infection on months and months, and that varies. So obviously you see a very low infection rate when it's cold and there may be snow on the ground, et cetera, and that starts to peak when we are outside, and that's May, June, July, August, September, usually for most areas. Now, on the island, we also see another bump in October, November, and even sometimes up into the first couple weeks of December, because we have a lot of hunters. Hunters sit in tree stands and they walk through the woods, et cetera, and at that point they become less aware that the ticks are still active, et cetera. So we do get quite a few infections and another bump that will actually equal the levels we see in either May or August at certain times of the year later in the year. So for those of you who are not as familiar with the actual symptoms, I want to focus on the left side of this slide where, looking at here's a number of cases, a little over 200,000 cases, and you can see that 71% of the cases have the characteristic rash. 30% are showing arthritis, and then Bell's palsy at 9 at the next most frequent symptom. And then you'll see cardiac, meningitis, and radicular neuropathy following along. As I mentioned, here on the island, we see less cases with the rash and quite a few cases of what we would call Lyme arthritis. Now, if you look at the right side of the screen, the general thought is there are 3 stages to this disease, and they happen in days and weeks to months to years. Stage 1 being the rash happening in days to weeks, chills, fever, what we call here the summer flu, which really doesn't exist. It's most likely some tick-borne disease, with the highest probability being Lyme disease. Moving to stage 2, which is weeks to months, where people will report facial, muscle, and other muscle weakness, muscle aches, joint aches, cardiac abnormalities, and sometimes palpitations. And then stage 3, where you really get into that chronic area, where chronic symptoms persist of muscle weakness, paresthesias, difficulty with speech, irregular muscle movements, and some neurologic symptoms. So let's take a look at what this rash actually can look like. So most people, it's been called the bullseye, and that's true, and that's the one that you would see at the bottom in this representation. However, I have seen patients with one bite and rashes over their entire body. I have seen patients with very pinpoint rashes and that are of a small centimeter in size, depending on where they were bitten, etc. Some of them are uniform, some of them blister. Some of them have bruising patterns. Some of them are just spread, they are not round at all. So there can be a variety of presentations. So to actually think that they're quite heterogeneous, and there can be numerous or single EMs. So in terms of treatment, doxycycline still remains the standard recommended treatment. Initially, clinicians would do 1 week, and then it bumped up to 2 weeks. Now it can be up to 3 weeks. Sometimes it's 1 course. Sometimes it's 2 courses, depending on the symptoms and the patient's complaints. There is a certain section of clinicians and providers that provide patients who have been what we call exposed. In that I mean that they have been bitten, but they have no obvious symptoms, but you've pulled a tick off, and patients become quite nervous. And there was one publication that showed that perhaps providing a dose of 2 pills, almost a loading dose, for lack of a better term, with patients, that this would prevent the development of the disease. And I'd like to strongly advocate against that. We see really no clear evidence that this treatment prevents the development of disease at all. So as I said, you may see treatment with doxycycline for another 2-week course if symptoms persist. The majority of cases are resolved after a 2-week treatment, but there are those patients who will require another treatment. For patients who cannot take doxycycline, either because they are working outside and they shouldn't have the sun exposure or allergy, etc., cephalosporins are also effective in this disease, and amoxicillin is used in children. The other thing that I'd like to stress is that there is no evidence that long-term treatment with antibiotics is effective, although there are several people who are on IV treatments, et cetera, of long-term antibiotics for chronic symptoms. There is no evidence that this is effective. So when we're testing for Lyme disease, what are we trying to detect? Those of us who do this for a living know that we're looking at antibodies. And these antibody production in Lyme disease takes on 2 stages. You have your first stage in the early stage, where they are the much larger antibodies, the IgM Lyme antibodies, and then later on IgG antibodies form. It's thought that seroconversion from IgM to IgG antibodies begins after about 9 to 10 weeks. You start to see, or months, that seroconversion take place. But I would caution to say that it doesn't always happen. I have seen patients here that have had persistent IgM antibodies up to at least 2 or 3 years after infection. So I wouldn't really use this as a rule of thumb. However, that is not the way we think of it. We think of seroconversion. And our current interpretation of Western blots, which I'll get to in a minute, actually uses that concept of seroconversion to interpret positive or negativity. But one of the things I'd like to also emphasize is that from patient to patient, obviously because we're talking about an immune response, there is a variability of antibody production. So that inherently also affects our ability to detect these antibodies and their presence from patient to patient. So I think we need to keep that in mind. None of this is written in gold standard. We know that these antibodies exist, but as in many immune diseases, you have antibody production that can vary from patient to patient in terms of time and amount. So this is the standard algorithm that is used, and in the CDC paper that we will be discussing, this is what they call the STTT, or the standard algorithm. Patients are screened at first presentation with the ELISA, the EIA. If it is positive or equivocal, they move to the Western blot, both an IgM and an IgG. If it is negative, you report it as negative, and there's no further testing required with this particular specimen. There is a note that if the disease duration is short, you can then do it again after 14 to 21 days if clinical symptoms persist, or if it's indicated at all clinically. If you look to the left side, positive or equivocal, as I said, IgM and IgG Western blot. If the blot is interpreted as positive, you report it as positive. Now, positive in this case is at least 5 or more bands present for IgG and 2 or more bands for IgM. If it is interpreted as negative, you report it as negative, and again, if the disease duration is short, you would redo it after you do another screen. So the Western blot in and of itself is not done in isolation. It is confirmatory testing of what you find in the EIA. For those of you who have never seen one, and again, I apologize for those of you who have, this is a representative snapshot of a IgG Lyme Western blot. And if you look to the far right of your screen, that is the positive control. On the far left is the negative control. And lanes 2 through 7 are patients. And here's where you can see the variability in response. Lane 2 and 3 would be considered positive, 4, 5, 6, and 7 because they have less than 5 bands would be interpreted as negative for an IgG Western blot. So this is actually taken from the Mayo Clinic and how they actually interpret and send out in terms of their interpretation guidance that is sent out on all their Lyme Western blots reports. And what I want to emphasize here is that there are often times you can have the presence of Lyme antibodies and still be interpreted as not having the disease. And it actually happens quite a bit. So if you look in the first boxes at the top, you have an IgM blot that's positive, you have more than 2 bands, but your IgG plot is negative. The laboratory interpretation of this is a couple of things. It could be either early disease, it's less than 4 weeks. So in other words, they are positive for IgM, they have not seroconverted yet. or it could be a past treated infection. So in other words, they've been treated in the past based on an IgM response, so they never seroconverted. However, in a lot of clinicians' eyes, this would be negative, and I'll get to that in a minute. In the second line, you see an IgM blot that is negative, less than 2 bands. You see an IgG blot that is positive. This is considered to be a past-treated infection, or the person has seroconverted. And again, clinically, this would also often be considered negative by many clinicians. And I'll explain in a minute. And then we have the standard of what is in the CDC algorithm: 2 positive IgM bands, at least 5 positive IgG bands, and that is considered clinically positive with some seroconversion taking place. And the last case is less than 2 bands in IgM, less than 5 bands in IgG. If there are no bands, they are negative, and if there are just a few bands, it's considered they may have had some exposure or it be a past-treated infection, and that is considered clinically negative. Now let me just make mention a little bit about the clinical interpretation. What often happens with most clinicians is they look at the blots as a total report. They are not looking at the results of the IgM blot, and they don't look at the IgG blot as separate results. So therefore, unless they see a positive in both areas of that IgG blot response, many clinicians who are not familiar with the disease will then say that that person is not infected with Lyme. So I want to just bring your attention a little bit to, as I mentioned, the validation study that I was involved with in 2014 and into 2015. And what we did here was we looked at our banked clinical samples and ran an analysis of these samples in the total VIDAS Lyme assay versus the dissociated assay, looking at correlations and the difference between the number of Western blots that would be required. And what we found was interesting. So if we ran the light total, in other words, the non-dissociated assay, anything that was positive, you had to run through a Western blot. In other words, a Western blot was required. Of those, 76 of them actually ended up being Western blot required and positive. So you had a percent results that were confirmed by Western blot of about 42%. When we ran the dissociated assay and only ran those specimens in each blot based on their positivity or negativity in each of the assays. In other words, if the Lyme M was positive, we ran the Lyme M Western blot. If the IgG portion was negative, we did not run the IgG. And the same for the IgG dissociated assay. So if the IgG was positive, we ran it in the Western blot for IgG and not IgM. I should also note that all equivocals were considered positive, so those were run on the IgM side as well. And using that paradigm, you can see that there was a significant difference in the amount of Western blots that were needed to be run, and that the percent of results that were confirmed by Western blot was significantly different. So what we actually showed in this assay was that we saw about a 23% reduction in the number of Western blots that were needed to definitively determine a Lyme diagnosis when you looked at the two different assays as opposed to being a total versus the dissociated assay. So let's now move to this current CDC assay. And what was done here was actually, excellent work, and I'd like to give anyone who's on the phone that may be from the CDC a shout out. It was very thorough and very excellent work. And briefly, let me just describe what they did. So bioMérieux recently launched its dissociated first-tier test, and that was available to everyone, I believe, as of January this year. The dissociated VIDAS assay uses a purified recombinant test antigens. But what's important here is the IgG part of the assay also includes the invariant region of IR6, which we would commonly call the C6. By testing the IgM and the IgG antibodies separately as a first tier, it provides an opportunity for those of us who use the assay for a different diagnostic testing algorithm than what you see with the standard testing. And I'll go through some of that in a minute and tell you why. So the rationale and what they did for methods was they used 471 bank serum samples that they had from Lyme patients. They used previously collected and published data on study samples from a variety of sources, including for the Western blots, for immunetics, in terms of IgG and IgM Western blotting, and they used the C6 assay also from VeriStripe. So the two-tiered test interpretation was performed according to recommended CDC guidelines and as previously reported for all samples. So that means that in order to be called positive on the Western blot, you had to meet both levels of that criteria, IgM and IgG. And I apologize if this is a little blurry. This is actually taken directly and dropped in from the paper. But the upshot is that there was a great correlation between the total assay and the dissociated assay. So the sensitivities and specificities were both very similar. One of the things that they did look at that clinically we don't always pay attention to, but in research we often do, is other potential comorbidities and confounding factors when we're testing for Lyme disease. And you'll see some of those cases here where they looked at specimens with other diseases, et cetera, that are sometimes known to cross-react in these assays. And you should note that the total assay had a higher cross-reactivity with other diseases than the dissociated assay. But as I mentioned, you can also, leave that up to most clinicians may screen for these at the same time, but since the sensitivity was and specificity was so high, most clinicians are fine with not also testing for these unless they get back a Lyme negative result. So here in this particular table, you can see the results that they got with a variety of two-tiered testing. So what they did here was what they called standard testing, where you see the total assay to the far left, the dissociated assay, the next column, and then the C6 assay as the confirmatory test in the third column. The fourth column is the C6 assay in the modified testing following the dissociated assay in the last column on the right. And what this shows you is that the sensitivities and specificities, when the two different strategies were followed, were actually pretty similar. There was a 76% sensitivity for the C6 out, what we'll call the modified C6 algorithm with the total Lyme assay, and a 77% sensitivity with the dissociated assay using the C6 as the follow-up assay. However, there were significantly higher sensitivities obtained when immunoblots were used as the second-tier test. So the modified algorithm approach in this case resulted in higher sensitivities compared to the standard testing algorithm. So what this is really saying is that, Western blot, although this is what we routinely use, may lack some sensitivity in terms of our follow-up testing. And that's probably best shown by this. It's a little less complicated than what you just saw. So if you look in total across the study, what the upshot is it reduced the number of Western blots required. So if on the right you look at the total assay, for all of those 471 that were EIAs that were initially performed, 159 of them were positive or equivocal. And in that assay, you don't know if that's IgM specific or IgG specific. You just know that you have a positive assay. That required 159 IgM immunoblots and 159 IgG immunoblots. Now, these numbers in parentheses refer to the numbers of immunoblots that were required if you used a 30-day duration of disease cutoff. CDC guidance recommends that anyone who is thought to be infected longer than 30 days, that you not run an IgM immunoblot, as those results are suspect. However, clinically, I think we can all agree that that rarely happens. You get a positive on that Lyme screen, the ELISA. You run both immunoblots. You really don't pay much attention to the duration of disease. You run them both. Nonetheless, out of the original 471, at the bottom you could see you had to run a total of 318 Western blots. In the middle, there were 942 EIAs performed. Now remember, that's 471 IgM ELISAs and 471 IgG EIAs. So initially you're running double what you would normally run because you're running them both separately. When you get the results from those, from there were 131 Lyme EIAs that were positive or equivocal and 101 Lyme IgG EIAs that were positive. Break it down further. When that was run as a confirmatory test for immunoblots, 131 of them were positive on IgM and 101 were positive on IgG. So 232 of those immunoblots were positive, which is less than what we saw in the first assay protocol. If you follow up the modified testing protocol and use the C6 as your testing, you'll see 471 C6 EIAs were performed. That asterisk I wanted to call your attention to is that this would exclude IgM testing, because as if you remember, I said the invariant region of the IR6 portion on the antibody is C6, and it is on IgG. It is not on IgM. So therefore, you're really only looking at IgG responses here. From the original 471, 112 of the C6 EIAs were positive or equivocal. Of those, 112 IgM immunoblots were run, 112 IgG immunoblots were run, and you came up with 224 total immunoblots. Now, one of the things that's interesting, no matter which protocol you went through, whether it was the dissociated assay or the C6 assay, you still ended up with fewer immunoblots than you do if you ran the total assay. So the overall findings that confirm that there is a reduction of at least 23% in the number of immunoblots needed when you run the dissociated assay as the first tier EIA. And that's pretty much very close and almost exactly the same number of reduction that we saw in the 147 that we ran. The number of false positives using the VIDAS dissociated assay was reduced by 50% compared to the total assay. And when either the total assay or the dissociated assay were followed by a C6 EIA in a modified approach, increases in specificity were observed. And finally, they mentioned that all modified combinations of testing were more sensitive than the standard algorithms. Now, whether or not we end up moving to a C6 approach, I think by looking at those numbers, you can really see some of the benefits of running a dissociated assay compared to a total assay. I mean, not only do they only corroborate the previous studies that I showed you, it significantly does reduce the Western blots needed for confirmatory testing, mainly because you only have to run the blot that is positive from either the IgM EIA or the IgG EIA. In our case, and what we see in our clinic is that you get first-line results of the specific Lyme antibodies that are present in infected patients. It allows you a quicker snapshot and window into where that patient is in their disease course. So in other words, if you have a patient who comes in who is IgM positive only, you can pretty much assume that they are in the early stages of the disease. They may not have serious symptoms at that point. However, they have not seroconverted at that time. Unfortunately, in order to confirm a lot of this, I'd have to say, serologically, it is very, very difficult to get a patient to come back in for convalescent testing. However, I can say in those patients that I have convinced to return in research purposes, we do find that borne out, that once they were treated, they did seroconvert later on. However, that is where we also see the persistence of those IgM antibodies for much longer than what you might clinically think they would be. So I'd like to say in closing, and I'd be willing to take any questions in a few minutes, that this dissociated assay actually provides your laboratory with quicker diagnostic results that you can couple with clinical symptoms that may or not be present, giving you a window into the disease course and potentially leading to an earlier diagnosis and treatment of Lyme disease. We all have heard the horror stories and know the issues for those patients who have in the past been told that their serology was negative and therefore they did not have Lyme disease and then went on to develop full-blown chronic symptoms and how they linger, and that population, unfortunately, is growing. And I think anything that we can do to actually increase the earlier diagnosis in this particular disease and treat it quicker would be clinically useful. So I'd like to thank you for listening, and Judy, I'll turn it back over to you for questions.
Thank you, Dr. Prisco, for your presentation. A quick reminder for our audience on how to submit questions. Simply type them in the Q&A box found by clicking on the green Q&A button at the lower left of the presentation window. Dr. Prisco will answer as many questions as time permits. And the first question is, how much of a cost reduction have you seen in your lab using VIDAS dissociated assays?
So I would say because the Western blot is so much more expensive than these VIDAS dissociated assays, and you can narrow down the amount you are running. My last calculation was that we actually saved about 37% in costs on this Lyme assay alone, just in reagents. Now that doesn't mean that does not include manpower, et cetera. The other thing that's important is remember you're also reducing costs to patients as well.
How long have you been using C6 confirmatory testing in your lab, and have you seen similar results to the CDC study?
I have used in the research setting and upon request C6 confirmatory testing, and I've been doing that now for about 18 months, and I do see very similar results as the CDC has shown. It's pretty remarkable. And like I said, I'd like to really emphasize that you do not see the same type of reaction in patients who are not IgG positive. So just keep that in mind.
Have you ever used the C6 peptide assay and seen the same results?
Yes.
How much of a reduction in a Western blot have you seen using the VIDAS dissociated assay?
We see at least on our end at least a 20 to 25% reduction in Western blots that are needed. And interestingly, it also depends on the patient population we get into the clinic. As I mentioned, because we're an island, we also see a lot of tourists. So some seasons we get a lot of people early in the disease, and you see fewer reductions. But on average, it's at least a 25% reduction.
What happens in the event a patient insists on Lyme testing and the EIA screen is negative and the Western blot is positive for IgM antibodies?
So I guess the question is how would you have an EIA that's negative and a Western blot? Well, all right, so you're saying you would have a Western blot that has less than 1 or 2 bands so that it would come back as some type of exposure. I have seen that in the past, and generally what I do is I revert back to symptoms, and if the patient is telling us that they clearly have symptoms, they would be treated. And, a lot of times those symptoms are very subjective, muscle aches, etc. And I think in the case of Lyme, it is always much more important to err on the side of caution. And in our case here, our clinicians would more than likely treat that patient rather than have them to go on and develop chronic symptoms.
Can you clarify the significance of the C6 region of the IgG?
Yes. So what you're looking at in the C6 region, whether or not you want to consider it significant, is it's just another target. So there's an invariant region on the IgG antibody that is present that you can also target, and it actually confers a little bit more sensitivity in terms of the detecting the IgG antibody, and it is essentially another way to look at the presence of IgG antibodies.
What is the reason for the C6 assay only looking for IgG, and is there any evidence that IgM antibodies don't react with C6?
Actually, there is some cross-reactivity that I have seen personally, but not having used it in a volume that I would be comfortable saying that there is no reactivity. I would say you could probably expect that.
Do these tests also indicate co-infections like anaplasmosis?
Actually, no, they do not. Because these are Lyme-specific antibodies. There is some crossover. There are some inflammatory mediator antibodies that are produced, but they're produced in a low enough level that these are Lyme-specific antibodies. However, I would caution most clinicians, and have many times where even here on the island we see at least a 5 or 6% co-infection rate with other tick-borne diseases. So even if you've ruled out Lyme, it would be, also good to make sure that people are not co-infected with other tick-borne disease.
Where would Lyme PCR fit into the algorithm?
At this point, PCR is not useful in anything but cerebral spinal fluid. The actual spirochete DNA doesn't appear to be present high enough in plasma to be used in a plasma level, so it's really only used in the CSF at this time. Speaking personally, again, I have tried using a very nutrient media to immediately inoculate cultures to try to grow the spirochete. And I have to say the actual success rate of growing it is pretty abysmal. It's pretty tough to do.
If the C6 invariant is present only on IgG, why is the immunoblot IgM run on the C6 assay?
That's a good question. I actually, the only thing, and I think, we may have to ask our CDC colleagues, but I think the idea was to put the specimens through the same type of paradigm that they would have seen normally. So you're going to run it through both, but the specificity really leans much more heavier on the IgG side than it does on the IgM side.
Please elaborate on the identity of the multiple bands on the Western blot.
I'm assuming by identity you're talking about the markers. So on the Western blot there are several different types of antigens. So when you look at the bands, there are a collection of a known 9 or 10, I believe, that are known to be present in Lyme disease, and that's what you're seeing as markers on the side there. So the 17 kilodalton, those are actually protein markers for antibodies, and what you see is the presence or absence of those particular bands on the Western blot. Some of these you see in IgM as well, and some of them appear at different stages of the disease. I've sometimes seen that as true and sometimes as not. However, what you see on the right side of that particular slide are the antigens that are proteins that are normally screened for in an IgG Western blot.
If the erythema migrans rash is only 71% at best, why does the CDC consider that a requirement for a confirmed positive? And the person says, I know you can't speak for the CDC, but can you give an opinion on this?
Right. All right. So let me just say that originally was the symptom that was used as a diagnostic marker for Lyme, and I think it's we're now seeing it more and more, and enough prevalence and incidence, and realizing that that may be a bit artificial, but because that has been used as a diagnostic criteria, that actually still exists. However, most clinicians will look for the rash, but if they don't see it, that does not mean, similar to that, if they don't always get a positive serology, will they say that this person does not have Lyme disease. So I think, people are getting better at saying, okay, they don't have a rash, but I'm going to test them anyway.
Do the antibodies persist after treatment?
Actually, they do. They can persist sometimes years after treatment. I have patients who come in to the clinic on the research side who I was working with who have had infections up to 6, 7 years ago and still have both IgM and IgG antibodies. Perhaps not to the level that would be considered positive on the Western blot, in other words, 2 and 5, but they do definitely persist, which is why it's really important to get a very detailed clinical history from these patients.
How often do you see persistence of IgM for prolonged periods of time, say many years?
As I just said, I would say that I've seen the persistence in probably, I'm trying to think of our data bank, probably in about, I want to say, and I'm just, thinking off the top of my head here, don't quote me on this, probably in about 20% of the patients that we have in our data bank have persistent IgM antibodies for longer than a year.
What is the prevalence of Lyme disease in the tick population?
That's an excellent question. We recently just did a survey of both the deer and tick population to see basically how many deer we had in a particular square area because they were easier to detect than the white-footed mouse. And then an estimate of certain areas of where we know the ticks are quite prevalent. And here on the island, we see at least 50% of the ticks here on the island carry Lyme disease, and another 30% of those will carry more than one tick-borne disease. So I think it's safe to assume that if you have a tick on you here on the island, I would assume it's carrying Lyme and to seek assistance immediately.
With the VIDAS dissociated assay, are both results reported to the physician, and if so, is that problematic for their interpretation?
Actually, it's not, and I do report both, and they are both reported. We have done a lot of education around this assay here to physicians to train them to look at both what they were getting before and what they're getting now. So they really do have a better understanding of what they're seeing. So it hasn't been a problem for us, mainly because we did a lot of education around it so that they understand what they're looking at. And then they also realize that they may only get one and maybe not two blot results back. But they are quite comfortable with the dual result and really like the ability to know which of the two antibodies they have present or both.
What is the value of the Lyme PCR, and how does it compare with the EIA?
Well, the Lyme PCR has very limited use. As I was talking about, it's really only used in cerebral spinal fluid and some joint fluids is really and so it has a very, very limited use. The EIA obviously is much more well used and oft available first tier screen. So unless you're got someone who's has a hugely engorged joint or is complaining of a headache and nothing else, the Lyme PCR really doesn't have much use compared to other tick-borne disease PCRs where you're actually, whether that be anaplasmosis or babesiosis per se, or in terms of those PCRs, which are quite predictive.
Do you test CSF for Lyme, and if yes, what method do you use?
We don't do it here on the island. We do send that off to the Mayo Clinic, and I believe they use their own PCR-developed method, so I can't speak to that.
You said you had a 30% savings of cost of reagents, even with buying twice as many screening kits?
No. So cost of reagents in terms of, if you're thinking of it in terms of, because you have to run one of each, the actual screening kit cost is not double. And when I said I had 30% of savings, I was talking about also that you did not have to run as many Western blots. So that was included in our savings estimate.
To clarify, we used the dissociated VIDAS, IgG, and IgM and have been sending positives to our reference labs for full Western blot as opposed to just IgG Western blot or IgM Western blot. Oh, hang on one second, more of the question. So if just EIA IgG is positive, we could send only for IgG Western blot?
Correct.
Great. Is there any evidence?
Go ahead.
No, please continue.
I was just going to say, by standard and guidance, you only run blots on those EIAs that are positive. So if you don't have a Western blot or a EIA and IgM say that's positive, you don't need to run the blot.
Is there any evidence of the penetration of non-U.S. strains?
Actually, that's a good question. And I think where we're actually seeing that is in some other, what they're calling other tick-borne diseases through the Lone Star tick that is now carrying a Lyme-like disease. It is very similar. However, its trajectory in terms of infection is quicker and a little more virulent. And it doesn't appear as if, and what we see in that particular disease is an IgG and C6 reactivity and less of an IgM reactivity. So there's some question of whether or not that's actually even a Lyme variant or not. But that's all that I'm aware of. In terms of spread throughout other regions and areas of the U.S. from, over the past 20 years is a lot of things. People are traveling more, number one. Their pets are traveling more, et cetera. And there is more of a tendency for people to be, outside hiking, et cetera, and they may not be aware of ticks and tick-borne disease.
Do you believe the warmer weather will cause a large number of cases to spread to other states with presently low numbers and see an overall rise in all states this year that would be significant enough for the media outlets to report it to the public?
That's a good question, too. I know we see a rise here. We're already seeing more cases now in May than we did last year, mainly because we had a pretty mild winter. Now, whether or not that translates to other places that had a mild winter, I can't say, but I imagine if we're seeing it, they probably are too.
Okay. Looks like we may have time for one more question. This person says they had technical difficulties, so they joined us a little bit late, but they're asking, which island are you referring to?
Martha's Vineyard.
Okay, thank you.
Off the coast of Massachusetts.
Okay, we can wait for more questions to come in, but during that time, I would like to once again thank Dr. Prisco for her presentation. Do you have any final comments?
I would just actually like to thank everyone for attending, and if you have any questions or whatever, if I can be of any help, Maru has my contact information, et cetera. You can feel free to reach out to them, and I'd be more than happy to help you.
I'd also like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today will be addressed by the speaker via the contact information you provided at the time of registration. We would also like to thank our sponsor, bioMérieux, for underwriting today's educational webcast. This webcast can be viewed on demand through November 8th, 2017. LabRoots will alert you via email when it's available for replay, and we encourage you to share that email with your colleagues who have missed today's live event. Until next time, goodbye.